If you've had a sleeve, I'm going to talk about a sleeve first, and then I'll talk about a bypass. Okay, so the only way to check it is to have a X-ray study called a barium swallow. And that's where you drink that chalky white liquid and you stand in front of an X-ray machine and you watch the white fluid go down into your esophagus and then go into your weight loss surgery. And the white fluid lines your anatomy. It lines any hollow tube. It shows up black on the X-ray machine because it's denser. And that's the only way to tell if your pouch has stretched out, okay? So I'm going to burst some bubbles here. That bullshit thing about the 5-day pouch test, that's bullshit. There's no such, it will not show you if you stretched out your pouch or not. That's an empty promise. All that's doing is resetting you on like just getting junk eat out of you. So no 5-day pouch test, okay? So stop wasting your money on that stuff, okay? It will not tell you what you need to know. The only way to do it is through an X-ray machine, okay, called the barium swallow. Now, my patients are pretty fortunate because I've got an X-ray machine in my office. So every time they come to see me for follow-up, and which is probably about every 3 months, I like to see my patients, 3 to 6 months. I always do a barium swallow for them. Now, it's not always a good thing because they can't eat that day, so they're on smoothies and liquids that day. But we can always see how their sleeve or their bypass and everything looks, all right? So don't waste your money on the 5-day pouch test or any of that stuff, all right, because it will not do it. You need a barium swallow. Now, that's one. Another way to do it is to get what's called an EGD. That's where I put the camera endoscopy. That's where you put the camera down a patient's mouth and take a look at the pouch, okay? It's not as good because you can't, it's harder to size it. Now, when you're getting one of these two procedures, the surgeon should be the one who does it, okay? So some programs will send patients to a radiologist and they'll do this barium swallow, and a radiologist has no idea what a bypass is or a sleeve is. They'll do their standard protocol. They give you way too much barium. They'll give you these fizzers, this air contrast stuff, these crystal bubbles. Tell them not to give you that. If you had a bypass, you're going to feel like so bloated. So I've seen that mistake a lot. And I've also seen people who go to a GI doctor to get an endoscopy and they have no clue what they're looking at. So you really need to see a bariatric surgeon. So some of people, like you have to travel a long way to see a bariatric surgeon. Trust me, it's worth it, okay? So the thing I want to impress upon you is travel. It's worth it. It will save you a lot of headaches because it doesn't matter if you have this x-ray done or you have the endoscopy done. If the doctor does not know what they're looking at, it's a useless test. You know, the doctor could be very well trained. He could be very nice. He could be really sincere and wanting to help you. But if he doesn't know what the fuck he's looking at, it won't help. Does that make sense? So you really need to go to a bariatric surgeon, specifically your bariatric surgeon, all right? You're worth the wait. I know sometimes it's hard to travel and all that stuff, but this is the only way to see if you've stretched out your pouch, okay? Got it? So 2 studies, that's it. Okay, so you need those x-rays. Now that might cost you money, I get it. You might have to a copay, etc. You might be one of these patients who went to Mexico or went to a different country for your weight loss surgery, and you might not see. You might have to pay out of pocket again. I know. That's a long-term cost of maintaining weight loss surgery. Okay. Now for the sleeve, I'm going to draw a sleeve for y'all real quick, okay? So this is the stomach, diaphragm here. With the sleeve, I staple off and remove 75% of the stomach. So now all you have is a sleeve of stomach left that's shaped like the sleeve of a jacket, a sleeve of a shirt. That's why it's called a sleeve. There's no device. So when we're making a sleeve, we want it to be very uniform. So I'm going to erase this so you know this is what you have left. All right. The surgeon aims to make it very uniform. Like I teach my patients 2 fingers wide, 2 fingers long. Ultimately, your sleeve is going to be 2 fingers wide, 2 fingers long for my patients, okay? Now, what makes the sleeve stretch out? So what happens, the whole sleeve doesn't stretch out. That's a mistake. Usually what stretches out is the top part, like that. Okay? This stretches out. Now, Dr. Vuong, why does this stretch out? 2 reasons. One is a technical reason from the surgeon. One is behavioral from the patient. And I'm going to teach you that here in a little bit. So with a sleeve, if the surgeon, when he's making the sleeve, does not make it uniform and he gets too close to this bend, like this is too narrow right here. So you don't want your sleeve too narrow. Some people say, Dr. Vuong, make my sleeve really small. Like, no, you don't want it really small, man. You want it just right. 2 fingers wide, 2 fingers long. If you make it too narrow, what happens here is when patients try to eat, they really push the food down and the food runs into like a roadblock right there. We'll call it like a roadblock. And like, you guys ever drive on the road and the highway gets congestion because something happened, a car wreck or construction, and everything backs up? So the food will back up and it will stretch out the top of your pouch, the top part of your sleeve. Now, that is seen on the barium swallow that I showed you. And sometimes, and I've had to do this on 2 patients who were not my patients, but you go in there and you trim off that top stretched out part. Does that make sense? The whole sleeve, very rarely does the whole sleeve stretch out. And it's due to this narrow spot. It's like, I'd say 95% of it, okay? So that's the technical side of stretching out a sleeve. 1, there's a surgical problem, they made it too narrow, and then 2, the patient behavior. Second half of this talk, I'm going to show you how to avoid this. But with the Roux-en-Y gastric bypass, what happens, let's say you have your old stomach here like that, okay? The surgeon will come in here and staple off your stomach pouch, okay? And then he'll go disconnect your small intestine down here, like that, okay? And then he moves up this end, this far end, okay? So I'm going to move up this far end, connect it to your gastric pouch, okay? And then this part that got disconnected, I sew to the side I brought up. Okay, so I'm going to get a little technical now. So this is your gastric pouch. We shoot for about an egg-sized pouch, but there's a lot of variability. All right, I'll call it the gastric pouch. We shoot for about the size of an egg. Now, some of you guys who are watching who've had the bypass going, size of an egg, Dr. Vuong, that's not very big, and I can eat more than egg, right? Amen? I'm going to explain to you why you can eat more than the size of an egg here in a second. So this is what we moved up here is called the jejunal limb. Sometimes they call it the roux limb, but I'll just call it, it's jejunum, which is a part, which is part of your small intestine. So it's small intestine. Now, share the broadcast real quick for all you bypass people, because I'm about to blow your mind, show you what happens here, and explain to you why your little egg-sized pouch, you can eat more than the size of an egg. I'm about to blow your mind, okay? First thing about the gastric pouch, different surgeons do it differently. Some surgeons make what's called a micro pouch, and some of you guys go, I want a micro pouch, I want a micro pouch. Trust me, you don't want you might or might not want a micro pouch. It causes other problems. Some surgeons make a long, skinny, more tubular pouch. And that also has its benefits, but also has its problems, okay? So here's what happens. Now, when this jejunum goes up and gets connected to your egg-sized pouch, different surgeons connect it differently, all right? This is called an end-to-end. I connect it straight like an end-to-end, like plumbing. But some surgeons, you can also connect it, let me move that revitalizer. Sometimes you can connect it like a candy cane. So you do what's a side, end to side. So the end of the pouch to the side of the jejunum. And sometimes the candy cane goes to the right, sometimes it goes to, this is left, sometimes it goes to the right. All right. So that's different. Sometimes the surgeon will put it on top. Sometimes the surgeon will put it on below. Okay. Now, here's why you can eat more with a pouch. Someone write this down for me. It's not the pouch, the gastric pouch that stretches. One, someone's head just exploded right here. Right? If you had a bypass and you can eat more, it's not because your gastric pouch has stretched out. That's why that 5-day pouch test is stupid, right? Your gastric pouch is not what's stretched out, most likely. Usually it's still nice and small, okay? The stomach tissue is very tough. It's hard to stretch it out, and there's no stricture, right? Now you could stretch out the gastric pouch if this connection between your small intestine and your pouch is too small. If that happens, then you could, but usually that leads to more stomach ulcers and stuff, like ulcers. So what stretches out? Number 2, mine's about to blow. It's the jejunum that stretches out. It's the jejunum that stretches. So it's this small intestine that stretches. Because the small intestine, it's chitlins, right? I mean, that tissue, I mean, it has the capacity to, it's really thin. The membrane of the jejunum is real thin. The membranes of the stomach is real thick, so the stomach doesn't stretch out. So what ends up stretching out is out here. So your jejunum ends up stretching out here. So now your capacitance, that's how much food you can hold, went from the size of an egg to the entire jejunum and the pouch. Does that make sense? So now you've gone from an egg size to like this whole thing. Now look at that. Now some of you watching that's a bypass going, dude, that is about how much I can eat. Is that true? Amen? It's like the size of your hand. You can eat like a whole, sometimes you feel like you can eat the whole size meal, right? Regular meal. So sometimes also this candy cane will stretch out too. And now that creates a blind loop. Blind loop. So 2 things. Surgically, if you have an extra loop here, I can go in and remove this candy cane loop so that that's gone. Some surgeons, if your jejunum has stretched out, will staple off like your jejunum, so get rid of that again. So they try to reconstruct this. This is why you don't want a micro pouch, because if the surgeon has to reconstruct your connection, it's really hard to sew to anything, and you're actually sewing it to your esophagus, and that's a whole different mess, let me tell you. So has this been some good aha moments where you bypass people? It's not the pouch that stretches, it's the small intestine that stretches. So because the small intestine is what's stretching, no pouch test is going to make it shrink, okay? Which is the second or the third thing. This is some good surgical nuggets for y'all. Y'all getting this? Okay. So here's a big one. Put a star by this. I hope you're taking notes. You really want to take notes, okay? It will not go back. It will not unstretch. So stop asking me. It will not unstretch. Once you've stretched out your sleeve, once you've stretched out your bypass, pouch, your jejunum, it will not unstretch. You can't make it come back small again, okay? So, but don't panic. I'm about to teach you how to do that. Okay, we got about 10 minutes left in the broadcast, and then I'm going to switch over to my Sleeve Academy group, okay? So, I think that's all I wanted to say. That the only way, if you have something anatomically wrong, like this part and this part, it takes surgery. That's what I want. Surgery to correct. All right. Now some of y'all sitting there going, I want surgery. I want another surgery. Let me tell you this, okay? It won't, even if you have a surgery to fix this, someone write this down. It will not feel the same like when you first had the surgery. You will not have that same restriction feeling. You will not have that same hunger stuff, like hunger cessation, like go away. It won't reset it back to like when you just first had weight loss surgery. It just won't, okay? Your body's too dang smart. So if you're watching and you follow me and you love me, you have to understand another surgery might or might not be the answer. It's usually not the answer because it's usually not the problem. I would tell you, roughly, this is only surgical reasons. It's only about 10% of the time. Only about 10% of the time is this the reason. All right.